Next, let's talk about disorders of the adrenal cortex. And so we'll take a look at hypercortical function first. And the diseases that we have within the hypercortical realm is Cushing syndrome, which really is more of a group of clinical manifestations that results from chronic excessive cortisol, regardless of the cause. And we have Cushing disease, where we have excessive anterior pituitary secretion of ACTH. So just to remind you of that pathway, the hypothalamus is going to secrete our corticotropin releasing hormone. That goes to the anterior pituitary gland, tells it to secrete ACTH, which then travels to the adrenal cortex and tells it to release the corticosteroid or cortisol. And then, of course, we have our negative feedback loop here. So when we have ACTH dependent hypercortisolism, that means we have secretion of both cortisol and adrenal androgens that are increased, and our cortisol releasing hormone is inhibited. And this extra release of cortisol is going to cause some manifestations like we see pictured over here, where we get weight gain in the trunk, the face, and in the cervical region. So that is giving us what we call moon face. And this is an individual with that got diagnosed, and within 4 months, you could see the accumulation of adipose tissue that took place. And the fat that develops in the cervical region creates a little fat pad in the back known as a buffalo hump. And then, of course, we've got the truncal obesity that we pointed out earlier. And then we can also have glucose intolerance because of cortisol-induced insulin resistance and increased gluconeogenesis. Remember, taking things like fat and protein and creating glucose from it, and glycogen storage that we are breaking down to get glucose through the liver. And then we've got protein wasting that takes place, which is caused by the catabolic effects of cortisol on the peripheral tissues. And so the muscle wasting leads to muscle weakness. You could see that they've got very thin arms and legs despite adipose deposits in other areas of the body. We may also see that we lose some of the collagen within the skin, and that makes their skin very thin and weakened, and so it's prone to getting damaged more, things like bruising. We can get ulcers that can develop, and we can also stretch it out and get these striae that develop, the purple striae on the abdomen here that we see pictured, that develop because of the stretching that takes place due to the adipose deposits. Next up, we have congenital adrenal hyperplasia, which we have a deficiency in cortisol production that then kind of causes the body to want to increase ACTH concentration to try and stimulate that release of the cortisol. This usually results from an inherited deficiency of an enzyme that is critical for the cortisol biosynthesis. And so affected infants may result in an overproduction of mineralocorticoids and androgens, or both. So we can see that, especially for affected female children, they will become virilized, which means that they will kind of take on male secondary sex characteristics, and infants of both sexes are also going to have salt wasting take place. Next up, we have hyperaldosteronism. So if you picked up on the word aldosterone in there, that means we're gonna have excessive aldosterone. We do have 2 different types. We've got the primary, which is also known as Conn syndrome, and this is when we have that increased aldosterone secretion from an abnormality within the adrenal cortex. Usually we've got a single benign aldosterone producing adrenal adenoma, or like a benign tumor on the adrenal cortex that is causing this. And within the secondary type, we've got an extra adrenal stimulus of the aldosterone secretion, and most often this is due to a secretion of excess angiotensin II in response to decreased circulating blood volume. So if you remember, When we have low blood volume, we can secrete renin, which then is going to turn into angiotensin 1 and then angiotensin 2, which signals aldosterone. That goes to the kidneys and causes a reabsorption of sodium, which then pulls in more water, and then we are able to increase the blood volume. So manifestations would be hypertension. We've got hypokalemia, and that is because as we are trying to reabsorb the sodium, we get a renal excretion of hydrogen and potassium, and we get hypervolemia because we're pulling in all that salt and all that water. As we said earlier, we can have a hypersecretion of those androids. So if we have a hypersecretion of adrenal estrogens, then we start to see a feminization where we see an expression more of the female secondary sex characteristics. And we could see this type of tumor that may be estrogen secreting more evident in males as a result of gynecomastia, testicular atrophy, and decreased libido. Whereas if we have a hypersecretion of adrenal androgens, then we start to see virilization take place more. So expression of the male secondary sex characteristics. And that's what we're seeing over here on the right-hand side. It's a virilization of a young girl by an androgen secreting tumor of the adrenal cortex, and we can see masculine features taking place such as a lack of breast development, increased muscle bulk, and hirsutism. Now let's talk about adrenocortical hypofunction or hypocortisolism. First up is Addison's disease, and this is also known as our primary adrenal insufficiency. This is going to be an autoimmune mechanism that destroys the adrenal cortical cells. And this tends to develop because there's an inadequate stimulation of the adrenal glands by ACTH, because there's some type of inability of the adrenals to produce and secrete adrenocortical hormones. So an example of what may happen is if somebody had a chronic infection that affected the adrenal glands, such as tuberculosis, that would cause them to have primary adrenal insufficiency. And this happens a lot in underdeveloped countries. So then there are these autoantibodies and autoreactive T cells that attach to the adrenal cortical cells and attacks them. If it happens in childhood, they call it type 1. If it happens in adulthood, they call it type 2. And it's associated with other autoimmune diseases too, such as Hashimoto thyroiditis or pernicious anemia or hypoparathyroidism. And so it can happen due to any of these types of infections or disorders. And as this continues, it can lead to Addisonian crisis when we have a hypotension that can lead to vascular collapse and shock. You could see some of the other changes that take place here, such as skin changes, including a hyperpigmentation or vitiligo. And then we've got the secondary hypocortisolism. This is when we have decreases in ACTH, and that leads to an adrenal atrophy and results from when someone has been exposed to glucocorticoids for a prolonged period of time. Notice that it's exogenous. So they are taking glucocorticoids for a while, and that glucocorticoid suppresses the ACTH and causes the adrenal atrophy, as we said. And then once that glucocorticoid is taken away, the body has a hard time going back to its normal corticosteroid genesis in order to create its own cortisol production. And so we don't really see the hyperpigmentation in this type, but other manifestations we can see are fatigue, skin changes in other ways, anorexia, nausea, vomiting, and diarrhea. And the treatment is to take a lifetime of glucocorticoids and mineralocorticoids to replace those hormones through therapy. And the last thing we're going to talk about are tumors of the adrenal medulla. So this is when we have hyperfunction of the adrenal medulla, and it's usually caused by some type of tumor. The first type you could see pictured here on the right, and this is a pheochromocytoma. It's a tumor that is developed from the chromaffin cells that are making up the adrenal medulla. And the other type is a sympathetic paraganglioma, and that you could see takes place in several different places along the sympathetic paravertebral ganglia of the thorax and the abdomen, and even in the areas such as the pelvis. And these tumors can secrete catecholamine, so epinephrine, norepinephrine, and these are excessive levels, so we get clinical manifestations that can include persistent hypertension, headache, pallor, diaphoresis, tachycardia, and palpitations. And these tumors are rare, but about 10 to 20% of them are malignant and can metastasize. So if they're not malignant, then surgical excision could help remediate the situation. These tumors do tend to be extremely vascular and can rupture and cause massive and potential fatal hemorrhage.